Welcome to Senadipin Education Foundation once again. Knowledge is a powerful weapon. Arm yourself with it. We started this knowledge exchange program way back in 2007 by releasing a brochure from our institute by Antonio Longo. Then we started Senadipin Education Foundation in 2012 by releasing a set of educational DVDs. The DVDs were released by Professor Seon Han Kim from Korea. Then we started free fellowship programs, 6 months and 1 year fellowship programs in basic and advanced laparoscopy surgery. And it is still continuing. We give hands-on training in both basic and advanced laparoscopy surgery. With the advent of COVID, we changed the platform to online. And the logo was released by none other than Professor Palani Velu from India. We had live surgeries in online platform. We started the live surgeries with the Facebook Live. It was a laparoscopic anterior section. And then we did a lap Beeple operation in YouTube Live. The link was shared to the members of Senadipin Education Foundation. Then we started having live lectures with world leaders. Recently, we started international fellowship programs in laparoscopy, hepatopancreatobiliary surgery, colorectal surgery, and upper GI surgery in Japan, France, and Korea, respectively. These are the list of candidates who are selected for minimally invasive hepatopancreatobiliary surgery fellowship in Tokyo Medical University, Japan. And these two candidates are already in Japan, having the fellowship there in Tokyo Medical University. In the season 1, we had 28 webinars with the world leaders. And one of the webinars was conducted by Professor Oli Linguist. The ERA Society tweeted in the Twitter. Our chairman, Professor Oli Linguist, gave a wonderful ERA talk at the recent Senadipin Education Foundation, one of the largest online meetings with over 1,400 delegates from 72 different countries. We have appearance in social media. We have 29 WhatsApp groups and Facebook group also. We have a YouTube channel. All the webinar videos are available for free reference in the YouTube channel of Senadipin Education Foundation. Last time we had a talk on how to measure outcome of a surgical procedure by none other than Professor Pere Alain Clavin from Switzerland. Today we have an eminent leader in radiology. He is my friend actually, Dr. Amit Pathak. He is a senior consultant radiologist in Adyawat Hospital, Meerut, UP, India. He has got 25 years of experience in the field. He graduated and postgraduated from Kasturba Medical College, Karnataka. He has contributed to the book titled Endoscopic Ultrasonograph. He has hosted many international US workshops, published many articles in index journals, and he is a soft-spoken person, and he is a friend of mine, and he is a historian. He has written books on history also. He is a historian also. Welcome, Dr. Amit Pathak, to this show. The show will be, the talk will be mediated by me because I need to know how you do a ultrasound in SPB field, because I am an SPB surgeon. So we will discuss. Before that, all the participants are requested to mute their mic on entry. If possible, kindly acknowledge their name by renaming your device. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. Everybody will be given permission to unmute their mic if they want to speak. If you are on a portable device, please mute your audio and hide your video. And for any queries, please contact us at senadiban@gmail.com. Thank you all for joining. I give the mic to Dr. Amit Padak.
Hello, good evening, Dr. Baji from India. It's a pleasure. And as you said, we are friends and we have had some wonderful time in some of the good workshops in the past and discussed this field and seen its role. And the role of ultrasound becomes especially important because the focus is primarily on CT and MRI, whereas ultrasound somehow is slightly accepted in general terms around the world that it has only a limited role in these pathologies, though, as you will see, it has a very large contribution to management of hepatopancreatobiliary diseases. It was actually US which added to the transabdominal ultrasound and gave it another dimension. And when you mix transabdominal ultrasound with endoscopic ultrasound, you can do wonders. And today I'll be primarily focusing on transabdominal ultrasound because it's an introductory talk. I will not go into details of hepatic disease assessment or pancreatobiliary disease assessment by US, but I'll give some examples through which you will be able to comprehend the beauty of this investigation when it comes to decision making related to hepatopancreatobiliary diseases. So I think I'll immediately start my presentation, and I'll love to have question answers after the session is over. I'll start with, actually, I will, in my presentation, I will not go into what ultrasound is because we all know it. We are all consultants and all of us have been exposed to it for years now. I'll just start with the basic idea of how it operates and then go slowly step by step into hepatopancreatobiliary ultrasonography, its assessment and how you report it and how you talk about it. We all know that a sound frequency greater than 20,000 hertz is used in transabdominal ultrasound. The transducer probe is actually both a mouth and an ear. It is a mouth because it sends the ultrasound beam, and it's also an ear which receives the reflection of the ultrasound beam back when it comes and takes it to the brain of the machine. And the brain then creates an image which we and you can see and analyze. Now, the advantages of transabdominal ultrasound, and I am focusing here only on, as I had said, on transabdominal ultrasound. It's an amazing imaging tool which is in the hands of the clinician himself. And I take myself, even though I'm a radiologist, to be a clinician because I work in a hospital. And the greatest and the best decision of my life was to walk out of my small clinic around 20 years ago and walk into the hospital where the real decision making and analysis of the patient is taking place. So when you operate an ultrasound machine, and this is the advantage of the machine, you also are a clinician because while the radiologist who is trained to do ultrasound is seeing the patient, you can be there with him all the time. and analyze the patient simultaneously. You can do it any number of times, and this is compared to CT scan, as there's no ionizing radiation. Because it is conducted live on a patient, you are also observing the various movements, including the diaphragm, and it's a live demonstration of what is happening inside the patient's body. It is a real-time investigation. You can come, see, discuss, analyze, see clinically, and then come to an interpretation. That is the beauty of an ultrasound machine. And finally, one great advantage of ultrasound is interventions. In our institution, we rarely ever go in for CT interventions. We do all of them with the help of ultrasound only. And again, the advantage being real-time display while the needle is going inside the patient's body. Obviously, there are some major disadvantages. It is nearly 100% operator dependent, though we are having very good machines now, which do quite a good display. Still, as in your clinical practice, you must have seen, ultrasound is basically operator dependent. It's a shadow play. So there are no real images. Ultrasound creates a set of images which are different from reality. And that is why a slow learning curve. And all those among you who would have gone into endoscopic ultrasound will immediately know what I am saying. There is a slow curve just because these are not real images. This basically shadow play. And this slowness of mastering the art of ultrasound actually is one of the reasons why many people try to go into it. Very few continue with it. But I will tell you, and as you will see after my presentation, it is not at all that difficult. It's just that you have to train your brain to understand the images, and it just catches on with time. Ultrasound display is primarily brightness modulation, that is B-scan. Brightness is, as you can see, the dots down there. These are small pixels extending from white to black, all the shades. Now, these different shades of gray will create an image which we interpret. And how does this various shades of gray form these small shades of gray pixels on the image which create an image? Well, obviously, the basic difference would be wherever the density is extremely different. So if you have water, air, and bone, obviously there will be a major difference in density. Most organs are filled with water. That is why all of them, their structures are seen differently. There is a word in the center which I have written, interface. Now, this word is the core of ultrasound imaging formation and is very easy to understand. Wherever the ultrasound beam, when it enters the human body, reach a point where the difference in density between the two structures is highest, there is maximum reflection of ultrasound beam back into the machine. And an example is air and water. And that is why wherever there is air, ultrasound is not able to penetrate. And that may be gut air or maybe lung air, or even in perforations, air if it comes out of the gut. So interface is the idea we must understand first, and varying degrees of interface through the body create the ultrasound image. There's a very basic principle which is also used in transabdominal versus endoscopic ultrasound imaging. The principle is, if you increase the frequency, the quality of image created is very good, but the penetration of ultrasound beam is very less. If you reduce the frequency, the image is not that of that quality, means the resolution of the image decreases, but the penetration increases. Therefore, when we do endoscopic ultrasound, we are using high frequencies, but we are not able to go beyond 5 centimeters. Whereas when we have to do transabdominal ultrasound, we have to put the probe over the surface of the patient's body, then obviously we want the ultrasound to penetrate the whole body from the anterior abdominal wall to the posterior abdominal wall. And for this, we do use low frequencies, but there the disadvantage comes in that the image resolution decreases. So a lot of times we mix transabdominal and endoscopic ultrasound to get the best analysis. One has the advantage of depth, the other has the advantage of resolution. High frequency, greater resolution, lower frequency, greater depth. This is the basic principle of ultrasound. Now, when we approach a patient, and I hope that after my talk, many of you start doing ultrasound yourself. The advantage is obviously for a clinician any day. As I had discussed earlier, you conduct the procedure, you simultaneously talk to the patient, you see a lump. If it is there, you can palpate that lump with your hands. You can touch the abdomen of patient and then confirm the diagnosis with history. So you are doing an ultrasound examination with a probe. You are simultaneously doing a clinical assessment, and you are also simultaneously taking history of the patient. So the assessment of the patient is as good as there's no other modality which gives you this wide spectrum of spectrum through which you analyze and come to a diagnosis of the patient. Obviously, we will confirm with other subsequent investigations, but ultrasound added to your clinical skill is actually wonderful. How to hold a probe? It is simple. You have to hold it like you hold a pen. We are all used to holding pens. That's how you hold the probe. This is a high frequency probe which you use sometimes. The second point to remember while holding the probe is all ultrasound probes will have a marker, sometimes a knob, sometimes a depression. Now this decides which is the direction of movement of the probe. What I prefer to do is put my index finger over it. So whenever I'm holding the probe, my index finger is on the knob. I know how the probe is pointing, and then because it is a two-dimensional image, the ultrasound will send a two-dimensional cutting ultrasound probe will send ultrasound into the machine, and whenever you move the probe, it is as if the ultrasound is cutting the body of the patient like a knife. So whichever direction you are moving the probe, the ultrasound knife will cut at that point, creating the image of that place or location. A very basic point is in the ultrasound screen, where should we have the left and right, and what should be the axis actually of, and I'll come to that earlier slide subsequently, of depiction. Ultrasound screen, when you see on the ultrasound machine, cranial is on one side in one axis, in the long axis, whereas if you do the transverse axis of ultrasound imaging, as I said, it's a two-dimensional imaging, it cuts like a knife. So if you cut transversely, ideally, the right of the patient should be on your left and the left of the patient should be on the right. And why I said this is because when we approach a patient, we are taught traditionally to always approach the patient from the right of the patient. Similarly, when you put that ultrasound beam, it will cut the body in the perfect axis which is needed. It is the same principle is applied in a CT scan, and same will be applied in ultrasound. The liver of the patient will come on your left, whereas his spleen will come on your right. This is the profile axis on which you have to cut a transverse and long axis. And when I go to my next slide, you'll understand what I was meaning by transverse and long axis. Second is when you are moving on the ultrasound machine with the probe on the patient's body, you should not move irregularly like you see in this traffic moving on this road, but you should be in order. And the systematic approach on every patient will give you the best results while doing an ultrasound examination. So when you hold a probe, there should be a protocol which will follow from right, taking a whole circle, coming back to the center, rather than moving randomly on the patient's body. What I prefer is going to left lobe first, going to right lobe first, going to right kidney, going back to left kidney, spleen, and coming back to left lobe and pancreas. So I take a whole circle precisely in every patient, whatever the disease, original disease may be. When I was talking of this long axis and transverse axis, this image will actually help you out much better. When you see the long axis of the patient at the transverse, they are in red lines. And my probe should move in this axis towards the right of the patient, towards the left of the patient. Subsequently, turn it 90 degrees, go superiorly towards the head of the patient and inferiorly towards the legs of the patient. So when you move like this in straight lines from right to left and caudal to cranial, you will take multiple sections of the organ which you are analyzing and come to the conclusion as to which place to measure. Because when you go up and down like this, you take the maximum size and measure it precisely. There are only two places where you do oblique movement. And the first is on the right over the liver. Because of the presence of ribs, as you can see, these thinner arrows are the markings for the ribs. Therefore, in this area, you have to move the probe slightly obliquely while moving caudally and cranially so that it uses the intercostal space as a window. You can see in this case that the liver is there, but there are shadows of the ribs cast on the river. That is what I was talking. You turn it slightly oblique and move between the ribs, jump from one intercostal space to another, and then the analysis becomes better. The second point when it comes to the liver and porta assessment is how to get porta hepatis. And a lot of people find it difficult to see the CBD and portal vein when they start an ultrasound examination. The simplest thing is to do is you take the subcostal margin, you take the midpoint of the subcostal margin, put the probe with the axis of the probe pointing towards the anterior superior iliac spine of the left side, obliquely across the abdomen, at the midpoint of the subcostal margin, and the porta hepatis is invariably there unless the liver is severely enlarged. This is the porta hepatis image, and you can see the portal CBD and portal vein. On the right is the gallbladder. Now, gallbladder is a bad organ. Gallbladder has no fixity. It tends to lie in multiple places in multiple axes. So once you've identified the porta hepatis, then you have to move your probe irregularly. This is the only place you have to really move it irregularly to search the longest axis of the gallbladder. When you are analyzing the spleen, again the same problem is there because of the presence of the ribs. So you move the probe obliquely across the spleen to get its longest axis, as you can see in this patient. The rib, you have gone between the ribs are casting shadows on the sides where most of the rib has been seen through the single image through the intercostal space. Now, after this basic of how to do it, I'm telling you, if you move it systematically through the methods that I've told you, left to right, top to bottom, oblique in liver, oblique in spleen, and transversely at porta, that's it. Your hepatoportobiliary ultrasound is no problem. It's just a matter of time. When you do multiple patients, you get used to it and and the habit comes in, and then you develop your own method of viewing every organ. Now, this is the most important slide for all those people who read an ultrasound in their life and who do or read endoscopic ultrasound images. These are three basic terms of ultrasound. The first is echogenicity. Echogenicity is the whiteness, how white an organ which is seen is. So hyperechoic or echogenic is the term used for whiter areas. Hypoechoic or echo-poor is used for relatively blacker, darker areas. And anechoic is for an area from which you are not getting any echoes. And this will be a cyst or a gallbladder or urinary bladder. Next is echotexture. Echotexture is homogeneous or non-homogeneous. Now, my next slide will put it up so easily in front of your eyes. Homogeneous is like silk. Non-homogeneous is the rougher variety of cloth. It is basically that. Whenever nature has given us any organ, the rule is all our organs are homogeneous, may it be spleen, liver, pancreas, or whichever organ. Wherever it becomes non-homogeneous, that means there is disease, as you will see subsequently in the later slides. When these two terms, ecogenicity and ecotexture, are combined together, that we use the term is ecopattern. So whenever we describe a disease area, suppose in liver or any other place in the abdomen, we use the word that the ecopattern is altered or ecopattern is non-homogeneous. That means this area is diseased, rest of the area is normal. This slide will show it very clearly to you. On the left is hyperechoic with homogeneous ecotexture. In the center, you can understand the difference between the context texture, as I was saying. In the below down is above is the gauze, which is very non-homogeneous, and below that is cloth, which is homogeneous. All organs are like this cloth, which are homogeneous, and gauze, which is there above it, is non-homogeneous, which is diseased area. That is what the ecotexture means. On the right is obviously eco-poor or nearly anechoic. After you understood these three terms, ecogenicity, ecotexture, and ecopattern, now these are the 1, 2, 3, 4, 5, 6, 7 terms in which you describe any disease. Even if you are doing an US, even if you are doing abdominal ultrasound, if you want to describe a lesion which you see, how will you describe it? This is the table which tells you how you do it. And in subsequent sections, when I'm taking up examples of disease, you'll immediately know what I mean by it. First, obviously, and this is actually description is in the reference to lymph nodes. But this applies to all masses as well, liver metastasis and a lot of disease areas. If there's suppose a small lesion in a rounded lesion in pancreas, also these parameters will work. The first obviously is location. You have to define where you are seeing the lesion. Second is number of lymph nodes, and if it's a lesion, number of lesions. Third is margins. In the context of lymph nodes, if we continue, well-defined margins or ill-defined margins. Ill-defined margins in the context of lymph nodes means most likely that these lymph nodes are of inflammatory origin and infective origin. And well-defined margins are in the context of lymph nodes more related to metastatic lymph nodes. Ill-defined margins in India is in when you see in lymph nodes, elongated irregular lymph nodes, you go more for tuberculosis, wherever well-defined rounded lesions will go more for malignant lymph nodes. Fourth point comes from the above, shape, whether they are elongated or rounded. Now this, in case of lymph nodes, as I had discussed, rounded lymph nodes more likely to be malignant, elongated lymph nodes more likely to be infective or reactive in origin. Next point is, as the earlier slide was, ecopattern. When you see a lymph node or a mass, what is the ecopattern? In the context of lymph nodes, ecopattern, if it is ecotexture plus ecogenicity of a lymph node, so you have a ecotexture which is non-homogeneous. Lymph node is more likely to be infective origin. A homogeneous ecotexture of a lymph node is more likely to be malignant. A lymph node which is nearly isoechoic with surrounding soft tissues is more likely to be infective. A lymph node which is hypoechoic, blacker compared to the surrounding soft tissue and hypoechoic, it is more likely to be malignant. This is for in the context of lymph nodes. Whereas masses, obviously, there is a variability, which if subsequently we'll take up talks on masses, sometimes we'll discuss. Next point is obviously calcification and liquefaction. Calcification in case of lymph nodes is more suggestive of chronic infective pathologies. Subsequently, the size, obviously. And another criteria for in masses is encasement of structures, that is, whether they are encasing vessels or tubular structures like bronchi, and what is the status of these. Now, when you've seen this table, you will see that size I have put as nearly the last point, because every lesion would have been small when it has grown big. So size, for me, technically, I don't feel it to be that important a criteria compared to the other criteria. So if you use the other criteria to grade a lymph node or a mass, you automatically, while using this terminology, will come to a probable diagnosis as to its origin. And obviously, the next point is doing an FNAC. And there again, immediately you, with the same day simultaneously, you can do an FNA of the diseased lymph node or the abdominal organ that is diseased by abdominal ultrasound or EUS, and come to a diagnosis. So you see, if you approach a patient of with ultrasound, use these parameters to grade the lymph node or diseased organ that you are seeing, and then do an FNA. Within the same day, you have literally covered most of the spectrum of diagnosis that you would do. Subsequent investigations will only be adding to your information that you have gathered. Most of the information is there in hand. That is the advantage of ultrasound, and which we are also using in our institution. Our protocol is, if we come to a lesion, first of all, we use these parameters to come to a probable conclusion. Subsequently, do an FNA. And after the FNA has been done, because either transabdominally or US wise, then we decide which all next stage of investigations the patient must be exposed to. So it shortens the time within which we come to a conclusion and a diagnosis. It saves a lot of money for the patient, because an ultrasound and an FNA is the only thing that he is doing, and we have got most of the diagnosis in hand. And our protocols for future assessment are much clearer after we have come to a very good probable diagnosis or a near diagnosis or a complete diagnosis through this assessment procedure. Now, this is one of the lymph nodes, and just as an example, I have taken it. I'm not adding any more lymph node slides, so that you understand what I was saying. The lymph node on the left that you see is elongated, well defined. It has a non-homogeneous echo pattern, and this variability of echo pattern, its length, is suggestive of an infective origin. On the right, in the same patient, you can see that some of these lymph nodes are confluencing. Confluencing lymphadenopathy in India is most likely indicates gives us an indication of tuberculosis. Though infective lesions, lymph nodes can be most likely to be confluencing. So you see, if you use those parameters which I had in the earlier slide of size, number, length, depth, echo pattern, you automatically come to a very good relative diagnosis. Now we go into this concept of echogenicity, echo pattern, echo texture, and use it to see diseases in organs. This is actually a normal liver, and there are two types of vessels that you see: hepatic veins and portal veins. On the right, you can see a hepatic vein and a portal vein marked out. All portal vein radicals have fat on their margins. That is why their walls appear echogenic or white, whereas hepatic veins don't have these, and therefore their walls are not seen. Hepatic veins, therefore, will be straight lines, whereas portal radicals will all be having echogenic white walls. This is a liver where echogenicity is increased, but echo texture is homogeneous. So this is fatty infiltration of liver. Some people will ask, fat is also liquid. How does presence of fat in liver make it white? Ideally, if fat gets collected in the liver should turn black. For this, I'll give you the reason through a slide which I had shown initially, and I waited for this. I didn't describe it there in detail because I wanted to come to this slide. What happens is that the fat that is there in the liver or pancreas, but we are here focusing only on liver, is in the form of small lobules. Now, these small lobules, you can imagine bunches of micrograpes filling the liver. These small lobules, because every lobule of fat is separate, creates so many small interfaces of variable density. Therefore, when the ultrasound enters the liver, which is fatty infiltrated, these tiny lobules that are spread throughout the liver will create so many interfaces that most of the ultrasounds get reflected. And this higher degree of reflection back into the transducer gives the whiter image. Another example, if you want to get what I was saying, is happens in polycystic disease of kidneys. In polycystic disease of kidneys, again, there are these multiple microcysts other than the big cysts in the kidney. These microcysts are like small grapes spread throughout the kidney at a microscopic level, and they reflect so much of ultrasound that the polycystic diseased kidney also has a white parenchyma or echogenic parenchyma. Now we have this example of increased echogenicity, but echo texture is homogeneous. I'll just touch on fatty infiltration for a minute before going on, because it's a very good, very new and very fast growing subject at the moment. Fatty infiltration to define in a liver is very easy, because the portal radicals which were white, as you can see, the white radicals in this, portal radicals which are white are lost. So hepatic veins as well as portal radicals will all look like vessels passing through liver, and you will not be able to differentiate between portal vein radicals and hepatic vein radicals. This is the comparison. On the right, you have a normal liver, and you can see all the portal radicals are appearing, showing white margins. Whereas on the left side, if you see, the liver is completely white. The portal radicals are not seen at all. So this is what I was talking of, increased echogenicity. The whole liver has become whiter compared to a normal liver, which is on the other side. The opposite also happens. And the opposite happens where the liver is inflamed. And mostly in cases that we see are of viral hepatitis. So here what happens is the liver becomes blacker, and the portal radicals which were lost in case of fatty infiltration will become whiter, giving a starry-eyed appearance. So the terms which we'll use to describe this liver is echogenicity is reduced, echotexture is homogeneous. The texture is still homogeneous, but the echogenicity has reduced. And I'll show you one or two more slides on this starry-eyed appearance, and you can see the reduced echogenicity, the way it looks. The radicals shine out of the black background of the liver. And you can even see the portal radicals in such cases, because the beaker is so black and the fat around has become so white that the margins of the portal radicals as well as the portal vessels, artery and bile duct radical is also seen. Bile duct radical traditionally is never visualized in a normal liver. If you see bile duct, even if it is not dilated more than 3 millimeters, you should think of some degree of obstruction. This is the portal radical. It is defined, the artery, vein, and bile duct are defined because the liver has become so black. And I've enlarged the liver. Traditionally, you can see only the portal radical, but not the biliary radical or the arterial branch which goes with the portal radical. Next comes a cirrhotic liver. And now the same points I'll use here. Though the ecogenicity in this cirrhotic liver is nearly the same as normal liver, its ecotexture is non-homogeneous. This cirrhotic liver, it's lost its homogeneity, which nature had given it because of the cirrhosis that has occurred. And this is also responsible for the nodularity of the margins. Other than nodularity of margins, you see this liver and you know this is a cirrhotic liver. You can see on the left how the cirrhosis actually shreds the normal homogeneous pattern which nature had given this liver, and it becomes completely non-homogeneous. So cirrhotic livers you describe as having non-homogeneous ecotexture. There's a comparison between a liver and a spleen I've got in this slide, because a massively enlarged liver transversely through the upper abdomen I'm seeing, and the spleen was also enlarged, and they're touching each other. You can easily now make out the difference between the eco patterns of the liver and spleen from the simple slide. Spleen also has small branches of splenic vein passing through it, which have ecogenic walls, but the liver portal radicals have a very typical white border, all of them slowly merging and moving towards the porta hepatis. Next, we come to the pancreas, and here also we'll use the same terms which we had described earlier to describe pancreatic pathologies. This is a normal pancreas, and you can see ultrasound is so good. It is amazing. And all thin patients who are fasting, this is the pancreas you see. Only place where there is a slight problem sometimes is the tail of the pancreas. But in nearly most cases, this is how you can differentiate nearly all organs around the pancreas and the pancreas itself. This is a patient with acute pancreatitis, and you can make out that the pancreas is, first of all, its margins are ill-defined, its size has enlarged, its shape has changed, body is larger, tail is not significantly that large, its eco pattern is non-homogeneous. In this particular pancreas, there is no calcification and no liquefaction. So this defines acute pancreatitis. So when you'll be defining acute pancreatitis on transabdominal ultrasound as well as in EUS, you have to use it, define it exactly in the same terms as which we had seen earlier of margins, size, shape, eco pattern, calcification, and liquefaction. Next is chronic pancreatitis. Again, the same points that we have, the terms which you used earlier. Size in chronic pancreatitis may reduce or may remain normal. In this case, the pancreas did not show significant reduction in size. But as we all know, in a lot of these chronic pancreatitis, the pancreas parenchyma shrinks and there is reduction in size, which is more, as in my personal experience, in the region of body and head. Eco pattern is non-homogeneous, margins are well defined, and we have calcification. So this pancreas, using these terms, we come to the conclusion of chronic pancreatitis. Now suppose the same pancreas, its size would have increased, its margins would have become ill-defined in some areas, eco pattern staying non-homogeneous and calcification staying as it is, we would have put it as acute pancreatitis on chronic pancreatitis. So the same terms, when you define an organ in those terms, you also immediately come to a conclusive diagnosis like you do in an equation of mathematics. Ecotexture and eco pattern description in a very interesting case. Now, in this case, we did a transabdominal ultrasound and we found a few specks of calcification only in the uncinate process, not in the rest of the pancreas. You could see through transabdominal ultrasound that you could localize the calcification in uncinate process only. CBD was clear of it. So these did not appear to be related to the CBD. We do it in EUS. On EUS, we found that this was not calcification. These are calculi in a dilated pancreatic duct of the ulcerate process. And there was focal pancreatitis within the ulcerate process only. And how this is seen, beautifully seen in this slide. This is the ulcerate process. We are focusing only on the ulcerate process by EVAS, and you can see the echo texture of the ulcerate process. Next slide. The same patient, pancreatic neck. You can see the echo texture of pancreatic neck. This is normal pancreas. Most of head, neck, body, and tail having normal pancreas. And you can see the echo texture, which is homogeneous. And you can see the ulcerate process, chronic pancreatitis, and the echo texture is non-homogeneous. So this description, I think this is the best slide to show anyone what the term echo texture means. This focal chronic pancreatitis of ulcerate process of pancreas. The gallbladder, I am not going into details of gallbladder. Commonest thing you see helps you obviously is in cholelithiasis, gallbladder stones. But another place where a gallbladder is your best friend is hepatitis and congestive liver disease. This gallbladder wall is edematous. You can easily make out the thickness of the wall, and this edematous wall, it's the best of friends. It will indicate hepatitis, and if you've seen the IVC, the other thing it will indicate is a congested liver secondary to congestive cardiac failure. And in recently in the past 10 years, we have been more and more seeing this type of gallbladder in a lot of these viral fevers which occur after rains. And we are seeing it in dengue patients and a lot of other viral diseases, simple, sometimes viral fevers, undiagnosed etiology. There also you are getting this. Probably this is all part of the hepatic inflammation which has occurred secondary to a systemic viral fever, viral disease. The next is obviously CBD, and you can see there is a CBD stone calculus which is 1 centimeter in length in a CBD of 8 millimeters. And you can make out it is lying just at the junction of the common hepatic and cystic duct. So ultrasound is extremely, transabdominal ultrasound is extremely good. Nearly all cases of calculi are seen. The only problem occurs in patients who are fat, who have gastric stasis, and if the calculus is lying within the ampulla, there the problem may occur. The same advantages with periampullary masses. You can see it is so well demonstrated. Pancreas, stomach, liver, CBD, duodenum, and you can see the mass so clearly. You can even measure it. Subsequently, you go in for an EUS. It can show even duodenal diverticular. That is the accuracy level of a transabdominal ultrasound. Echogenic shadows at lower end of CBD, which are linear, we are very much indicative of a diverticulum, which is causing or not causing compression of lower CBD. A diagnostic dilemma until you do a endoscopy and an EUS, and then obviously you come to the final conclusion. In the end, the last part is ERCP decision making. When to do ERCP, when not to go in for a straight ERCP. We even decide the type of stent to be used, because sometimes the patients are not very rich. The economics is a very good criteria in a lot of third world countries. There, whether we can use plastic stents instead of distensible stents, ultrasound is actually the decision-making process which we have been using in our institution for nearly 20 years now. You can see this is the oblique section where the bile radicals are coming from both sides, the left lobe and right lobe, and coming close to the porta. I go down slightly. The right and the left main hepatic duct have formed, but they are not meeting. I go further ahead and I can see that the right and left hepatic ducts have met. Because the junction is still having a dumbbell shape, this is an ideal patient to use distensible stents. Plastic stents may also work if the patient cannot afford a distensible stent. And if this junction would not have been there, then we would have thought of other things to be done with this patient. So ultrasound is extremely good when it comes to assessment of biliary obstruction at the porta hepatis. Exact size, and in a lot of cases, even further investigations or further modalities of treatment can be decided only plainly with simple abdominal ultrasound. Thank you so much. It was actually just an introductory talk. So I just wanted to focus on some basic issues related to ultrasound and also uh, show you the beauty of this equipment. And I think all institutions can use it to a tremendous advantage while dealing with their patients. Thank you so much.
Thank you, Dr. Amit Pathak, for giving a wonderful talk and giving an very lucid presentation so that the participants can understand the basics of ultrasound. So there are 2-3 questions in the chat box. Before that, I'll be asking some questions regarding the yeah. Regarding the machine, actually, when you purchase a machine, so I'm working in a hepatopancreatibiliary unit. I do laparoscopic ultrasound. I do endoscopic ultrasound as well. I do abdominal ultrasound, and sometimes intraoperative open surgery ultrasound, probably the case of liver. So, which is the single machine can provide all the probes, like when I was working in a previous institute, it was Aloka. I don't know whether Aloka has now anymore there. It has occurred by Hitachi. So, what is the ideal machine which we can use in an institution where you need all the items?
Yeah, just a minute, sir. Implementation. Yeah. Yes. Actually, my experience is mostly limited to transabdominal and endoscopic ultrasonography as well as rectal ultrasonography. Surgical ultrasound, I have got a very limited experience. But I am doing nearly all interventions of linked to ultrasound. So that is the experience that I can add to what I am saying here. What we are using at the moment are Areta 570 and Areta 750. We have always used Hitachi for past 20 years, and there were certain reasons related to the use of the scopes that we are having in our department, and they were all compatible with Hitachi equipment. But so we have grown with it. So this is the point. I talk to certain other radiologists who are also doing interventions, and when you do interventional ultrasound, you really need a very good visualization. So they refer to as other companies, and probably the simple reason is they have grown with those machines. As the equipment matured, they have been using the same company's equipment for probably 15 years, and they are senior radiologists now, or 20 years. They have grown with that equipment. And now when they see equipment which is not of the same company or the same background, they find it difficult to use it, and they don't have very nice words to use for it. I think it is all you growing up with the equipment. In our department, we have always worked on Hitachi, and personally speaking, I actually am not able to move or to any other company equipment at the moment. We have the Areta 570. Recently, we have acquired Areta 750. In my personal experience, when I saw the resolution of Areta 570, I had never seen a machine like it ever in my life. And it's not to promote the company, but it is my own very personal experience. There was
Uh,
not too much of a difference between Areta 570 and 750 subsequently, but Areta 570 was a real jump from what I had been doing for years together.
that is
The
mainly
quality
for
of
the
imaging
mass abdomen.
has simply changed. Please. So
That is,
I feel it is the equipment, and there are a lot of other policies that reasons that come into play when buying an equipment. And I think the radiologist should will when taking this decision as to which equipment he should have. Most of the times, a lot of other reasons will outplay his own personal choices. But still, I think the standard equipment of particular range is all fine, except your experience with a particular machine. And in our case, we are using these two.
yeah. And regarding the use of Doppler, especially in a hepatopancreatobiliary surgeries, actually, we use a lot of Dopplers. We are not mentioned about this thing. And can you just brief about the use of Doppler and how do you identify these structures and all?
When we in transabdominal ultrasonography, actually, Doppler has two basic rules. And uh, the one is when it and which is the commonest when you are doing a case, live, and this, I think, for the same thing as with surgery also, while you'll be using it to identify a vessel, and immediately you put in the Doppler, you go on using the Doppler continuously, and to identify the flow, the vessel, the direct, because the direction of flow Doppler is not very good. So then it becomes your own judgment also plays a lot. Same as with US. While using the US, you have to use the Doppler all the time continuously to identify vessel. When it comes to my usage as a radiologist, actually I use Doppler in this role itself. And when it comes to liver, pancreas, and biliary for primarily identifying vessels, portal vein is the next stage which comes to whether there's flow or not, what is the grading of the flow. That's a complete different talk using portal veins. And obviously, where we use it in our regular assessment is portal vein thrombosis. So our overall role in use of Dopplers in how I operate, because surgical, I don't have that much of a personal experience. But when it comes to transabdominal ultrasound in US, our role has been primarily defining the vessels. It's not that high as compared to the peripheral vessels and other things. And I have also used elastography. I actually did the first presentation of elastography in my state in 2007. Uh, Elastography has stagnated. It could not grow beyond a point, and there are certain reasons for it. Doppler grew initially tremendously, but subsequently its growth has stagnated with other modalities taken. And I think a lot has to do with the CT angiography and high-end CTs coming up. They have suddenly prevented ultrasound, a lot of aspects of ultrasound from going because they have become redundant.
And regarding the elastography and fibroscan, actually, these are the two areas, gray areas. Actually, people don't really know clearly. There are some machines with the upgradation of elastography and upgradation of fibroscan also. And there are some machines with fibroscan alone. Can you elaborate on what is what and which is which?
If it comes to elastography, as I said, that I was one of the first to use it in a workshop in the country. Then we obviously used it a lot in US when we were growing as an US institution under Dr. Malay Sharma, and he was also he was experimenting with a lot of things of ultrasound, which can be useful for US. So his and my conclusion was nearly the same. And the problem probably did because we focused on lymph nodes only, because for elastography, because that was the place where we could try and use it the maximum. Our experience was because of tuberculosis in India, the results of elastography interpretation are not as good as they were in a lot of studies which came from countries like Singapore. And our we have you tried contrast ultrasound, everything. We found that it was not giving that major advantage compared to other modalities, and elastography was not doing very well. Personally, if you ask me, of all these years, I have not used elastography for assessment for a long time. And what our protocol at the moment is, you find a lesion, you grade the lesion by the other parameters that I had discussed, the 7 points. You come to an approximate conclusion, straight go for FNAC. And because you can do FNAC very well by transabdominal, we can do lymph nodes at porta transabdominally, and nearly all, wherever the transabdominal you cannot approach, you can approach by EOS. So we mix the two, go straight for FNA. And instead of playing around with a lot of things, come to and our FNA rates are quite good, and we've got an excellent pathologist, histopath lady. So, and so it has been quite a good experience. So a lot of these things I've just, because there's patient load and there's pressure. So that also works on our decision making at that time. So elastography, my personal experience till now has not been very good. Maybe they can evolve it further in subsequent years, and then it may take up some important role some places. And when it comes to fibroscans we are doing, it's a evolving field. And I think the only problem with fibroscans is that it is very much operator dependent. I've seen it in my own experience with our hospital. Now we know only this person will do fibroscans, no one else will, because how well the person does it. And we had, we have seen drastic results sometimes with people who are not so sincere when it comes to do a FibroScan. And otherwise, mixed with other modalities, it is one modality which will stay.
I'll take questions from the chat box actually. One question is about intraoperative ultrasound. What is the usual frequency used?
Dr. Baiju, I think this is one question you should first answer, because you are using it yourself, and you are a master at it. So
that will be because you are keeping the probe to the surface of the liver. It will be low frequency, that is 5 to 7 megahertz we are using. And I request Dr. Rajendran Velusamy to unmute.
Hello. Hi.
Hello.
Yeah.
Rajendran, you have some experience with the probes and the machines. You are given that you are using a particular machine. Can you just elaborate on that?
So I'm in Royal Marsden, London, actually, where we bought a BK machine, which has all the actually facilities like transabdominal, laparoscopy, and open intraoperative, and also laparoscopy intraoperative, and also robotic probe. Maybe we are surgeons with I think it'll be all tool in a one single thing. Probably maybe a future. It looks to be easy. It's operated. It's easy to operate also. So I think it looks to be an easy machine. Probably people can think and try about it. I think that's what my feeling, because I used to be a various machine. This machine has all the probes in many sockets, like one for.
What is this BK stand for?
It's a new company. It's a BK. It's a BK machine. The BK is a company
based from Germany.
Maybe I'll give the details. Probably I can send it maybe, but we just bought it. We started using for the last 3 months. Probably looks to be easy, because I think it's good for the surgeon's point of view. I feel like, because other machines have a lot of, this is operation wise a bit difficult, but this I find it a bit easy actually.
And you can apply in robotic also, is it?
Yeah, robotic. That's why I mean, because people want to pursue robotic, you can add you can just buy an extra probe, and then you can just if you're using in the future, because it's like a good investment for people who started using it. I think that should be a maybe. I think as a surgeon, I feel a little easier because you may not have too much complicated, knobs and everything. This looks very easy operator-wise, and also downloading the images. You want to show it a presentation, so it looks all a little bit easier for me, I feel. So that's what I used various type of interoperative machines. This looks to be a very the operation is a bit easier, I feel. Yeah, I think.
Thank you.
Maybe, I don't know exactly what the company and everything. If you want, I can go through the details and give it to you.
If you can mail, because I have shown the mail, Senadipan at gmail.com. If you can mail me, I can share to the participants.
Yeah, definitely. Yeah. Okay. The only thing you want to know, because the frequency wise, because as you said, if you for lesions from the surface to 5 centimeters, use high frequency, gives a better one. So just only thing I want to know, if you're using it on the surface of the liver, which is a better, higher frequency is better, or a lower frequency is better, or a 7.5 is better? What do you feel?
Yeah, low frequency is better, better for surface lesions.
Okay.
High frequency for deeper lesions.
Okay. 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 Understand. Yeah, that's fine. Because that's the only question, because I want to, because sometimes get it from the radiology, they give a better idea. Okay, that's a very good answer. Okay.
Thank you. Thank
and,
you.
And one more thing, when you talk about the hyperechoic around the portal vein, you said it's because of fat or because of the glycerine sheath. I just want to know.
Yeah, it's a glycerine sheath actually.
That is the why. That is the reason. So okay. Thank you.
Thank you, Doctor.
I just wanted to add a few points regarding surgical use of ultrasound is I can. Your point was very right regarding the knobology, which a number of knobs and the problem is that when they are selling these machines to us, they are selling so many things which are actually not needed.
Yes.
Most of these high-end equipment, the advantage is that because the systems nowadays which are coming, especially the new ones which I was showing, they are already set to the best possible visualization of images. So you don't have to touch too many knobs to improve the image or change the image. You get used to a particular image and you can ask the engineer to fix that image permanently, so that, and especially in the case of surgeons, and I can imagine, because sometimes it happens when I'm doing interventions also, my focus is completely on the patient. I cannot even turn my head to see what knob is there on the machine which I'm touching. So you have to completely put the machine aside and you have to focus on what you are doing on one side. And I think for that, these newer equipments are good. And in one equipment, we have called the engineer 4 times to set the image to every type of probe. We have high frequency probes and all 7 types of probes. So for 7 different probes, 7 different images. And this newer equipment can do that. And that is very helpful. You don't have to touch anything, maybe just brightness. Otherwise, you are just looking at the other side and looking at the screen, going on with what you want to do.
It is a very good topic for surgeons, actually, because you are learning a lot of basic things. But whatever, even though you're operator, but the basics are very, very important, because which we can't get it from anywhere. I think it's a very good lecture, I think. Yeah.
Thank you, Dr. Rajendran, for the nice words. And one participant was asked regarding how will you assess the IVC volume, IVC diameter, while most of the time you will be assessing the volume status of the patient. So you can put some light on that.
Yeah. So what I could have added that slide, but I was just focusing on the terminology rather. But I'll tell you a very simple thing. What you do is you hold the probe in your hand and you put it vertically, means in the long axis, in the center of the left lobe of liver. Move it slightly right and left where you get the IVC. So you'll get the whole IVC in one axis on the screen, like this, transversely on one axis. On the left, if you use the protocol that I have used, on the left, you will have the heart, and the right, the IVC will come tapering down from this side towards the heart. Now you put the probe on the left lobe straight and measure the IVC inner diameter from the anterior to the posterior wall. First thing is the measurement, which is traditionally said to be it should not be more than 2 centimeters. I prefer another, because we are doing real time, live thing, is how well the IVC moves with respiration. So if the IVC is changing its size with respiration, that means, first of all, there is no congestive cardiac failure. So you rule out cardiac disease. First point. Second, if still the IVC is relatively distended, that means most likely fluid overload. And if the IVC is completely nearly collapsed and it's opening up and closing, but not to a significant degree, and its walls are nearly touching each other, then you always should look at the degree of hydration of the patient. So best is to start the examination with IVC. When you see a patient and you have a probe in hand and you want to start with something, first put at the IVC. You rule out a lot of cardiac diseases. You see the degree of hydration of the patient. You look for fluid load overload, then come to the right lobe flow.
Yeah, thank you. Another question is regarding intraoperative ultrasound. Dr. Amit has already made a comment that he is not used to do intraoperative ultrasound. So, and during hepatectomies, there was a lecture on US guided hepatectomies previously by Guido Toselli from Italy. So you can refer to that lecture that is available in the YouTube channel of Senadipin Education Foundation. Dr. Jyotirmay has asked that question. And Prakash Raj has asked a question about contrast in USG. Can you elaborate on that?
Contrast ultrasound in US.
Yeah.
We have tried to use it in a lot of different cases in the past 15 years. And with mixed results, obviously, because the biggest problem comes in with the equipment itself. Whenever the equipment comes in, the time the protocols are changing and they are evolving. And every company our companies also in the different machines have come out with different protocols. And that actually creates a lot of confusion. But still, and then within this 15 years, CT has actually taken a jump. And that is probably one big reason why in the amount that you will do a contrast ultrasound, that's the financial aspect of the patient, you can do the top line CTs with certain with obviously much better results. So with the evolution of computer tomography, contrast ultrasound has been stunted. One place where in one of the workshops, after all the discussion, we come to the conclusion that contrast ultrasound is very good is to differentiate small cystic neoplasms of pancreas because they are the ones after contrast, even after injection of contrast, they'll continue to be completely anechoic, whereas a simple cyst will continue to be anechoic, whereas if it is a neoplasm, it will pick up some degree of contrast. So to differentiate small pancreatic cysts, solitary small pancreatic cysts, which are sometimes a big issue with the patient, and the patient comes and what to do. So after contrast ultrasound on EUS, you can be very sure about the diagnosis. And that is one place we found to be amazingly good. Other places are, till now, our experience has been. Question, can I answer a question? Very, very interesting regarding the diameter of CVD. We were discussing with some of our residents yesterday.
Yeah.
What is the diameter?
Yeah.
What is the normal diameter?
I have seen you locating the CBD very precisely when I was with you for some time.
Yes, sir.
So can you give some clues on that?
Yeah. The first thing is how to visualize the CBD. And for this, the one thing is that most of us, when we carry an image of CBD in our minds, is wrong. And that is probably something to do with when we are learning anatomy in our first year of medical education. CVD is not a straight tubular structure. It just doesn't come from the liver. It is a structure which comes out of the liver, goes to the pancreas, and then literally hooks into the duodenum. So it comes out straight into the pancreas, goes along the head of pancreas, slightly causing indenting it, and then turns and enters the medial aspect of the duodenum, medial posterior aspect of the duodenum, near where the duodenum is crossing the IVC. So when we have to look at the CBD by ultrasound, we don't have to just go straight from the porta downwards. The probe literally goes down towards the pancreas, then goes vertical. And at the lower tip, the probe actually goes in the opposite direction. It's like you are crossing like a hook towards the lower CBD. That is how you see the lower CBD. And so first you have the patient decubitus. You have seen the CBD at porta. Then you make the patient lie down straight. Follow the course of the CBD obliquely up to the head of pancreas. Turn vertical along the margin of head of pancreas to see the lower tip. So maybe sometime I have videos of that, how to sew, and then I can show it very well on patient, how on one side the image and one side how my hand is moving while that CBD is seen. Because that is how the CBD is seen. It's not a vertical straight structure. If you see straight, you'll invariably miss the lower end of the CBD. The second point was raised with the size of CBD. So I have done a study of around 400 cases transabdominal with a Department of Anatomy of LRM Medical College, Meerut, and they did some cadaver CBD diameters also. And we did post-cholecystectomy and normal CBD analysis. Then after all, what criteria I follow now, because I am in an institution which is a lot of ERCPs also simultaneously daily they are going on. We are doing decisions immediately, and 6 millimeters is perfect for a CBD. A normal CBD can be up to 9 mm, but between 6 and 9, if you get a CBD, one of the best things to do is do a simple alkaline phosphatase. Alkaline phosphatase, in my experience, is extremely precise for even milder obstructions. Post cholecystectomy cases, a CBD of 8 to 9 mm can be very much normal, with obviously a rider that a CBD of 4 mm may be having a calculus, and in some cases an elongated calculus in its lower part, which a 4 mm CBD, if you don't see trace it down to its near the head of pancreas, you will miss it. So it's a variable thing, but 6 mm is, when I see a 6 mm CBD, I've traced it as we are normal, I report it as normal CBD. When it comes to more than 9 mm, I suggest at least the basic liver function test to be undertaken.
There is a question from Dr. Rohik. In malignant obstructive jaundice, how will you differentiate between a metastatic lesion and a cholangiotic abscess?
Metastatic lesion answer and cholangiotic abscess.
Cholangiotic abscess.
Okay. And first of all, cholangiotic abscess invariably will have a significant degree of liquefaction. And whereas cavitating metastasis, if it occurs, the liquefaction is, the margins are very thin, soft tissue margins. In a metastasis, cavitating metastasis is actually not a very common entity. Secondly, the inside cavity will be larger and much more well defined, whereas cholangiotic abscesses will be multiple, small. They are not like amoebic abscesses at all. They will be hypoechoic to anechoic with varying degrees of echogenicity. Their inner liquefied lumen will not be very well defined. Cholangiotic abscesses invariably are very ill-defined hypoechoic patchy lesions, more on the periphery of the liver. And with obstructive jaundice, you are quite sure when you look at them that these are cholangitic abscesses. Metastasis invariably, most of the times, will be well-defined, rounded, nearly solid. If they are cavitating, their cavities will be much more clearly defined compared to cholangitic abscesses. This is my personal experience while doing ultrasounds in all these years.
Okay.
Though I think there was no specific study to demarcate, but this is what I have seen. Cholangitic abscesses are very poorly defined, hypoechoic areas, patchy, ill-defined, sometimes confluencing, more in the margins of the liver, and with obstructive jaundice, so you get an image that yes, these are cholangitic abscesses.
And another question is regarding the comparative size between portal vein and the CBD. And do you compare CBD size with the portal vein size at all? Or you
Never.
compare?
None. I have never a comparison because portal vein and CBD, they go in opposite directions at the porta. And portal vein is more a tubular straight structure, and its dynamics are very different, obviously completely different from CBD. CBD is a structure which is, it's not like a plastic pipe as we imagine. I feel it's more like a hose pipe of fire brigade. It is tubular structure is more alive. It has variable diameters all through. And I don't think we can compare the two ever.
Okay. Then coming to portal biliopathy. So what are the clues to assess the portal biliopathy? Means most of the time you'll be having collaterals there, portal vein will be compressing the this thing, collaterals will be compressing the CBD. Any clues to identify that portal biliopathy?
Yes. Portal biliopathy, we've done initial lot of work. Dr. Malay Sharma has published some papers, and we are also working with that. And portal biliopathy is best diagnosed seen by US. It is not a transabdominal ultrasound. You shouldn't see it, though, of course, portal cavernomas, transabdominal ultrasound is amazing. But whenever you have a portal cavernoma and multiple collaterals around porta from secondary to portal vein thrombosis, CBD is invariably not seen by transabdominal ultrasound. It gets mixed up within those multiple irregular vessels. Many of these collaterals are thrombosed, so you really do not know where is the CBD and where is the thrombosed collateral. So now US walks in, and US is amazingly good because US just does not show the indentations on the CBD by these collaterals. It can trace them, and it can even see perforators. So while doing US, you are better able to demark the status of the CBD. Its wall is seen, whether it is thickened or not thickened. You can define perforators. All that is done by US. So portal biliopathy US is the modality if you want to assess this patient, and probably if you want to go in for ERCP or some other modality, you would like to assess the status of the CBD. US is very good with that.
Okay. And one question is, can you comment on shear wave accuracy in liver and other abdominal organs? Have you looked at the shear wave of chronic kidney disease?
Shear wave and other things, I've not got much experience with that. We do transabdominal, we grade the, and after that we do shear wave. No, we are not doing it too much experience.
Okay, Dr. Anis asked a question regarding, we already discussed that question. Can laparoscopic ultrasound the US probe can be? Dr. Velusamy has answered that question. I think we have answered almost all questions. Another question is that is it accepted to measure the thickness of gallbladder to diagnose chronic polycystitis?
I'm not doing that. Actually, in cholecystitis, now this is a big question. When to say that this is cholecystitis? and if you see gallbladder stones. And second is when to say this is acute cholestatis, when to say chronic cholestatis. There's a period in all these 25 years when they said there is no chronic cholestatis. I still continued to talk of chronic cholestatis at that time also, because I feel it is an entity. I don't measure the gallbladder wall, but yes, I'll raise some few points here. The first thing is gallbladder wall is a very thin wall. As I'd shown that Edematous wall is thick. It is nearly, and all you surgeons must be knowing, it's a very thin wall. Thickening of a thin wall anywhere means disease. So in acute cholestatis also, as the case which I have shown, the wall is not significantly thickened, but it is thick enough to be easily measured. And that means the wall is thickened. And therefore, I would report it as cholestatis. Now, how to differentiate between acute and chronic cholestatis? The wall in most acute cholestatis will be thickened to a precise degree, and whereas in chronic cholestatis, it will be irregular. Another point which helps us in diagnosing chronic cholestatis is the overall size of the gallbladder. Acute cholestatis, now these are all variables, and there are no precise points, but yes, these help you come to conclusion. Acute cholestatis gallbladders are normal sized or larger than normal sized, whereas chronic cholestatis gallbladders, because the chronic process going on for years, they tend to be relatively smaller in size. And third point, as to the use of fatty meal examination in gallbladder, acute versus chronic, well, obviously, acute cholestatis also a lot of times, acalculable cholestatis is diagnosed with non-contraction of gallbladder on fatty meal, and same will be with chronic cholestatis. So this will not help. I think these are the differentiation in the wall is not the size of the wall, but whether the wall is smooth and thickened or irregular and thickened. That is more important when it comes to diagnostic.
Okay, when there is inflammation of the liver, sometimes the reports come as gallbladder wall is thickened. How will you differentiate between that wall thickness and the acute cholestatis?
And cholestatis.
Yeah.
Okay. I think I'll just open my slide presentation. 1 minute. Give me half a minute. I'll just open it and come to the gallbladder. And yeah. I'll go for it. Now this is acute cholestatis. You can see the wall. It is thickened, echogenic, and relatively thickened similarly all through with the same length, and not very lobulated and irregular. There is some degree of wall edema in the middle part of the gallbladder, anterior wall. Now, this is a wall of hepatitis. You see that this wall actually, I sometimes report it as like an onion peel appearance. Layers of hypoechoic and hyperechoic. It's like an onion have been cut, because this is edema of the wall because of secondary to the gallbladder inflammation. And this is thickening of wall due to inflammation of the gallbladder itself. And there is a clear difference between the appearance of the walls. This description of onion peel is not there anywhere, but I feel this is the best to describe edema secondary to hepatitis or congestive cardiac failure.
Okay. If you see some rim of fluid around, do you categorize this as acute cholestatis?
Sir, if pericholestic fluid is suggestive of acute cholestatis. And pericholestic fluid is not so common as we would think, but a presence of pericholestic fluid means it is a very severe acute pancreatitis. Because you can grade the degree of acute pancreatitis from, if the distended gallbladder, it's a normally distended gallbladder, but still it has pericholestic fluid, means it is severe cholestatis. This And pericholecystic fluid will not be found in these gallbladder wall thickening secondary to hepatitis unless there is generalized ascites.
Yeah. Can you diagnose cholangitis by ultrasound?
Yes, sir. Cholangitis can be diagnosed by ultrasound because again the CBD wall is thin and CBD wall thickens. And second point that you will get in cholangitis, even if the CBD wall is, especially when it comes to post ERC patients, when you have a blocked stent, and in such cases, cholangitis invariably there will be debris within the intrahepatic bile radicals, and you can see it very clearly. Even the bile radicals are not significantly dilated, you wait for some time, you will see echoes within the radicals, and they'll be also be mobile, and that is 100% indicative of cholangitis.
Okay. I think most of the questions are answered. Is there any question from the floor? They can raise a hand and ask the questions directly. Any participants who are having doubts can raise their hand and ask question directly. Then I think we can wind up the show. Thank you very much for accepting my invitation and giving an elaborative talk on transabdominal ultrasound. People are benefited out of it, and probably we will be coming with another topic on ultrasound itself with more elaborative views on the advanced things like port hypertension and all. So I thank all the participants who have joined and asked questions. And one question is, one person has raised his hand. His name is Muhammad Riaz. Can you please unmute Muhammad Riaz? Muhammad Riaz, please unmute.
Sir.
Yeah.
Hello, sir.
Please.
So my question is, before doing the laparoscopic cholecystectomy, what
Yeah.
are the features on ultrasonography that we have to must do the MRCP in that case, sir?
Before doing ultra, I didn't get your question actually.
Sir, when we are planning a laparoscopic cholecystectomy, we are usually proceed with the USG abdomen and we can proceed.
Yeah.
What are the specific indications in USG? Then we must undergo MRCP before the laparoscopic cholecystectomy.
Yeah. The question is regarding the use of MRCP before a cholecystectomy after you getting an ultrasound. Dr. Mohammed.
Yeah. Actually, our protocol is at the moment, and and because we got we mix both transabdominal and EUS. So our protocol is first, and before when a patient comes for cholecystectomy, and we do an ultrasound examination, we do the assessment of gallbladder as well as the CBD. Now, if there is any indication of obstruction, first of all, transabdominal ultrasound itself will pick up any form of obstruction that is there, and especially when it's coming for cholecystectomy, most likely that would be a calculus. Abdominal ultrasound in the right hands with the right techniques is extremely good. It can clear, from my perspective, it can pick up nearly all CBD calculi except the ones which are at the ampulla. So once a good ultrasound examination means you rule out most of the problems that would be there. Second, but still, if you have a dilated CBD, you are not able to see the lower end of CBD because of bowel gas, or the patient is very fat, or there are other issues associated with it. Even though the bile radicals are normal, second stage you do is an LFT, liver function test. Even if the LFT is nearly normal, raised obviously, then we think of ERCP, but if it is nearly normal, and we have to look at the cause of obstruction, then we subject the patient for endoscopic ultrasound. From the endoscopic ultrasound, we have looked at the ampulla. If we are, and then we have traced the CBD from transabdominal ultrasound, we have traced from liver to ampulla. From EUS, in EUS, we tracing from EUS, from ampulla upwards to the liver. So once you've done both the traces and you found that CBD is 8 or 9 mm, but still there is nothing there in the CBD, you can send the patient on for cholecystectomy. Now, problem comes in where by EUS you are not able to, for some reason, you are not able to access the ampulla, or you are not able to reach the second part of the duodenum. Only these are the cases in our system which we send for MRCP. MRCP, personally speaking, I have a slight problem because again, it is very operator dependent, equipment dependent. You know, there are a lot of variables. And unless you have a very good trained person whom you trust yourself, who's tuned to you for years, and you know the quality of equipment that is being used, you sometimes get a MRCP report and you actually are not able to trust. Then again, you will subject him to all the investigations. So what I feel is transabdominal, LFT, and EUS. If transabdominal clears the patient, then you can easily, without MRCP, go in for cholecystectomy. And subsequently, the steps to be followed, I have already discussed.
But sir, US is not available easily in
Yeah,
periphery.
probably you are working in a center because Dr. Amit is working with the Dr. Malay Sharma, where EUS is done left and right. So if
Yeah,
you
that
are
is
the
true.
center where EUS is not that frequently done.
Yes, sir.
Then I can just discuss. If US is not there, which obviously in a lot of centers in our city also. So if US is, then ultrasound, if it is doubtful, it's a dilate CBD, you are not able to see the lower CBD, you do liver functions, and they also, alkaline phosphatase also indicates that there's some degree of obstruction. Then obviously the next point will be MRCP. So MRCP is not to be done in all cases of prior to cholecystectomy. MRCP in only those cases where ultrasound with reasonably good hands says that yes, MRCP is needed because I am not able to see the lower part of the CBD.
Also, actually, you have to look at the first thing which you have to look before sending the for MRCP is the alkaline phosphatase. If it is elevated, it's better you send the patient if EUS is not available. Second thing is that if the patient has had a pancreatitis, so and having a gallstone, in that case also is better always to send the patient for MRCP. If, again, EUS is not EUS is not easily available in our institution. And next question is by Dr. Najja. Can you please unmute?
Thank you for a nice conference. I have a question for our speaker about differentiating liver masses in those who have cirrhosis and cirrhotic nodules. Looking for hepatocellular carcinoma and screening livers, which are difficult to examine like cirrhotic livers. What are your tricks? Do you use contrast?
Yeah, she's asking whether can you differentiate in a case of background of cirrhosis, can you differentiate HCC and the prominent nodules?
Yeah. Actually, this lot of times in discussions when we are doing cases in our hospital with the residents, that is the subject which is commonly raised, and this actually always is a issue which is to be done. So what you do is every cirrhotic patient, when you are seeing, the thing that helps you to differentiate between regenerative nodules and hepatocellular carcinoma is that its echo texture will be different from the rest of the liver. Most of the hepatocellulars will be different in their appearance from the rest of the liver parenchyma. Secondly, many of them have relatively marginated, well-defined margins, though sometimes obviously they don't have well-defined margins. Third thing that we always, it helps us is portal vein thrombosis in case of cirrhosis. So I feel if you have portal vein thrombosis in case of cirrhosis, even partial thrombosis. And even if you are not able to identify a mass on ultrasound, you immediately subject a patient to CT scan for further assessment, because portal vein thrombosis is one of the best indicators of development of malignancy in cirrhosis. But cirrhotic masses, they look different from the hepatocellular in a cirrhosis looks different from the rest of the liver parenchyma. Maybe in future, sometime when I have a presentation, I can have the two together, like I had these comparisons, and you can immediately make out where the masses, where is not, even just looking at it.
Do you give contrast to differentiate some of these difficult cases?
No, we are not using contrast ultrasound in case of hepatocellular secondary to cirrhosis. And we have used contrast for non-cirrhotic patients with liver masses, for grading liver masses, but not with cirrhotic patients. Cirrhotics, we subsequently immediately send for CT. That's what we are doing at our center.
Thank you.
Thank you, Dr. Najja. We have come to the conclusion. Thank you, Dr. Amit Pathak, for accepting my invitation, and thank you all the participants for joining.
Thank you so much.
We'll be coming with the next topic that will be on 18th of December on pancreatic endotherapy. It will be done by Dr. Rajesh Puri from Medanta Hospital. And after that, we will be having a webinar on groin anatomy on 8th of January by Jahan from France. Thank you all once again for joining. Have a good day and good night. There are people from outside country also. Thank you.
Thank you so much, Dr. Baiju. It was amazing, wonderful. And the questions were very interesting. They have poked me to think more and read more also.
Thank you.